Welcome to Persyst Grand Rounds, an online series of lectures hosted by Persyst, covering topics related to advanced EEG analysis for improving outcomes in both neurocritical care and epilepsy monitoring environments. My name is Marie Terrell, and I am the Director of Product Management with Persyst, here to introduce our speaker and topic for today's Persyst Grand Rounds. Through our customers, we understand the importance of investing in the EEG community through education, where expertise and knowledge can grow towards the utilization and implementation of EEG and quantitative EEG. The goal of Persyst Grand Rounds is to provide a platform for those with clinical expertise on topics of advanced EEG analysis as a way to connect with a broader community to share their expertise and knowledge so that we can all learn and grow together. Each online lecture features an experienced epileptologist or neurophysiologist presenting on a topic of their choice as it relates to EEG monitoring and analysis. You can visit www.persyst.com/grandrounds to keep up to date. The schedule is subject to change. The opinions and viewpoints of each speaker are solely their own and do not represent Persyst on any other commercial entity or commercial interest. Speakers are not required to include Persyst, its software, products, or services. The content presented was not prepared or edited by Persyst. Persyst is not providing any form of compensation. And finally, there will be time for questions after the talk today. Please write your questions in the Q&A area. There is a button at the bottom of your screen. A recording of this webinar will be made available to participants afterwards. I would like to introduce to you Dr. Susan T. Herman, Director of the Epilepsy Program and Professor in the Department of Neurology at Barrow Neurological Institute. She is board certified in neurology and the subspecialties of epilepsy and clinical neurophysiology by the American Board of Psychiatry and Neurology. Dr. Herman's expertise includes the treatment of drug-resistant epilepsy. She is a national leader in electroencephalography technology and interpretation, including video EEG monitoring for epilepsy, continuous EEG monitoring in critically ill patients, and high-density EEG and source localization. She is a member of the American Academy of Neurology, the American Clinical Neurophysiology Society, and the American Epilepsy Society. Dr. Herman earned her medical degree from Columbia University, Vagelos College of Physicians, I'm not sure I said that right, and Surgeons in New York City. She completed her neurology residency and a fellowship in epilepsy, clinical neurophysiology, and neuroepidemiology at the Neurological Institute of New York at Columbia Presbyterian Medical Center. Dr. Herman's clinical research focuses on epilepsy and EEG. She has served as a local principal investigator for multiple clinical trials of new epilepsy treatments, and she has also studied the treatment of subclinical seizures in children with cerebral malaria and the development of epilepsy in patients with progressive multifocal leukoencephalopathy. She is currently a co-principal investigator of the Epilepsy Learning Healthcare System, a network where families, community members, clinicians, researchers, and healthcare leaders can collaborate to improve care and outcomes for people with epilepsy. The talk today is titled Raw and Quantitative EEG for Identification of Ischemia. And with that, I will leave it and introduce you to Dr. Susan T. Herman. Thank you, Dr. Herman.
Great, thank you. Good morning, everyone. I'm very pleased to be with you today to talk about one of my favorite uses of EEG, which is use of EEG for identification of ischemia. So today we'll describe the characteristic EEG features seen in brain ischemia in patients with subarachnoid hemorrhage and ischemic stroke. Be able to select appropriate quantitative EEG measures for monitoring ischemia, and then integrate EEG and quantitative EEG into clinical management protocols for patients at risk for ischemia. So this is the same thing. These are my disclosures. None of them are relevant to this discussion, although I will mention that I clinically read EEG for detection of ischemia using a variety of software packages. A lot of what I'm going to be talking about today is covered in some of the guidelines that have been developed by the American Clinical Neurophysiology Society, and they can be found at the website at www.acns.org. So we all know that the clinical practice of ICU EEG is to improve the neurologic outcome in critically ill patients. Quantitative EEG and raw EEG allows us to diagnose electrographic seizures and other neurologic insults before they produce irreversible injury. We also need to communicate this diagnosis efficiently to the treating ICU physicians. And then once a diagnosis is made and appropriate therapy is begun, we can confirm the efficacy of treatment and avoid overtreatment using EEG. We also want to make sure that we utilize our resources efficiently and control cost. And I think when we're talking about using EEG to monitor ischemia, it is very resource intensive, and this use of resources is very important. So the indications for continuous EEG in the ICU are predominantly for detection of seizures, but there are other non-seizure related indications that are less commonly used. And today I'm going to be talking about detection of ischemia. So ischemia can occur during multiple diagnoses. Ischemia is most commonly occurring with ischemic stroke, in which case we don't know ahead of time that the patient is at risk for ischemia. Our monitoring with continuous EEG can be useful in ischemic stroke, and I'll talk about that towards the end of the presentation. But most of the time when we're talking about monitoring for ischemia, we're talking about patients who are at risk for ischemia because of something that's being done to them. So this is after vascular neurosurgical or interventional neuroradiology procedures. In patients who are at high risk for vasospasm after subarachnoid hemorrhage, in patients who present with hemodynamic lesions and borderline flow, and other patients at risk for in-hospital acute ischemia. So with ischemia, we see a progressive change in EEG that occur within about 5 minutes of acute ischemia. And the EEG changes occur before our currently available imaging techniques. And importantly, these changes occur when ischemia is still reversible for the most part. So when we see decreases in cerebral blood flow from the normal range of about 35 to 70 milliliters per 100 grams per minute, the first change that we see with slight decreases in blood flow are loss of fast activity, loss of beta activity. With more severe decreases in blood flow, we'll start to see slowing of the background, initially theta slowing, and then delta slowing. And all of these changes are reversible if blood flow is restored. And that's one of the major reasons that EEG is so useful, is because it can pick up these changes while we can still intervene and restore blood flow. When blood flow is severely decreased, then we see complete suppression of background activity. And at this point, the changes are irreversible. So when we're looking at EEG and quantitative EEG, the changes that we see depend on the blood flow, depend on the degree of ischemia, as I just outlined, with a progressive change in EEG features. But it also depends on the duration of ischemia. And so using EEG to be able to detect ischemia quickly is really important. And if the EEG is not being monitored appropriately and you can't detect and intervene quickly, then you would argue, why are we monitoring at all? You need to have a system in place to pick up the ischemia as close to real time as possible. The other point to make is that the distribution of ischemia is also very important in terms of whether we will be able to pick it up on EEG. So when we're seeing focal ischemia, usually there needs to be a fairly large region of the brain that is ischemic for us to see changes. And cortical changes are more easily seen than subcortical abnormalities. Many lacunes and subcortical strokes are not detectable on EEG at all. And we would expect to see the changes on EEG in the vascular territory of the region of ischemia. With large ischemic lesions, for example, with occlusion of the internal carotid artery, we may see hemispheric changes on the EEG. And then with changes of ischemia, global decreased blood flow, we may see generalized changes. But I'm going to be talking today mostly about focal ischemia. I'm going to just give a quick review of some of the most commonly used quantitative EEG techniques, and hopefully this audience is fairly familiar with quantitative EEG. But basically, we use a process called fast Fourier transformation to break the EEG down into its component frequencies and determine the power or the amount of activity in each of the frequencies. And this is taking the complex EEG waveform and performing a process like putting it through a prism to break it down into its component waveforms with each individual frequency and amplitude. And from this, we can create a frequency versus power graph, as we see here, with frequency along the x-axis and power, which is microvolts squared divided by hertz on the y-axis. And you can see here in this frequency display that there's a peak of frequency at 11 hertz, most likely the posterior dominant rhythm. And here we just see a demonstration of how useful this can be. This is a patient who has a normal posterior dominant rhythm that we see here in the back of the head, but also has a fast alpha variant. And in the fast Fourier transformation, we can see that there's peaks of activity in the occipital regions at both 10 hertz and 20 hertz, corresponding to these changes from normal alpha to fast alpha variant. And this is just the same thing with a close-up view. So once we've done our fast Fourier transformation, we can actually divide this into different power bands. So we basically just include the area under the curve for the delta frequencies, 0 to 4 hertz, theta, alpha, and beta activity. And we compute the fast Fourier transformation over segments of EEG lasting from 10 to about 20 seconds. Once we do that, we can determine the percentage of the power that's present in each of these frequency bands and stack them on top of each other, and then create a sequential series of these power calculations over time. So each 10-second segment over a 1-minute segment of EEG, kind of smush them together, and then get a graph of power in the different frequency bands over time. We can then display this as either absolute power, where we see the total amount of delta, theta, alpha, and beta activity. This is a graph of non-REM sleep, or actually sleep, and we see slow wave sleep here, stage 2 sleep with lots of spindles on top of it, and then back into slow wave sleep and successive cycles of sleep. We can also calculate relative power, which basically normalizes this. So shows us the percentage of power in each band, adding up to 100%. And this relative power display is useful for looking at fast activity, which is not very well seen in the absolute power band. So how do we then use this EEG? Well, we can break the EEG down into its component frequencies and get an idea of how much activity is present in the different bands. Here we see a patient's normal EEG with an alpha rhythm. So we see a significant amount of power in the alpha frequency range here, and that fluctuates over time. This is about a 1-hour segment of EEG. But if somebody has an electrographic seizure and suddenly has a change in the frequency components of their EEG, as we see here with this diffuse alpha seizure, you'll see increases in power. This is in the alpha and the beta range here that corresponds to those sudden changes in the power distribution of the EEG. So total power can be used as a very good seizure detector. In terms of ischemia, however, we're typically going to be looking at ratios of power. So the power trends for clinical uses are both looking at sleep cycles and spontaneous variability in the EEG, most commonly used for seizure identification. But in terms of looking at ischemia, we'll typically use ratios of power. I mentioned earlier that ischemia typically causes decrease in fast activity and increases in slow activity. And so we use ratios of power in the fast frequency band divided by either total power or by delta power in order to highlight changes that can occur due to ischemia. And I'll show you some examples of this later on. And these are most commonly used currently for delayed cerebral ischemia after subarachnoid hemorrhage. We can also use fast Fourier transformation to create color spectrogram trends. And this is a three-dimensional graph now where we color code the amount of power according to a rainbow scale, as we see here. And this color spectrogram allows us to pick out specific frequencies. So now we have our frequency along the y-axis, time across the x-axis, and the amount of power at each frequency is represented by this color scale, where deeper colors represent increased power. And we can see here a segment of waking EEG where we see the alpha rhythm, and then the patient is undergoing photic stimulation. And at each flash frequency, we see photic driving, resulting in an increase in power at each of these different frequency bands. We can also use the color density spectral array to look at normal EEG patterns. So again, here we see our alpha rhythm. The alpha rhythm attenuates, we lose it here. We start seeing some activity in the beta frequency band, which represents sleep spindles. And at the same time, we start seeing an increase in power in the theta frequency band, representing slowing during drowsiness. As the patient gets deeper into sleep, we start seeing more spindle beta activity. And then the patient wakes up and we see the alpha rhythm come back. So these color density spectral arrays can be very useful, again, for looking at the different frequencies present in the EEG. And in ischemia, we can look for changes in the amount of power in the alpha, beta, and delta ranges corresponding to the degree of ischemia. And we can also look for asymmetries. So the color density spectral arrays are generally represented as hemispheric trends, left hemisphere here at the top and right hemisphere at the bottom. Another very useful trend for ischemia monitoring are asymmetry indices, and I'll go into some more detail about these. So the first asymmetry index is an absolute asymmetry. So in this calculation, the power, which is again the amplitude squared divided by frequency, at each pair of electrodes is summed. The absolute value of these is calculated, and then they are summed over time to create a total asymmetry score that we see here in yellow. And the total asymmetry score is always positive because it's the absolute value. And the asymmetry score goes up with increasing asymmetry in any frequency or duration. So we can see here this yellow line. And as the EEG becomes more asymmetric, this asymmetry index increases and then gradually returns back to baseline. On the other hand, the relative asymmetry index compares the power at each pair of homologous electrodes, but this shows laterality because it basically compares the power right hemisphere versus left hemisphere. So if this trend goes up, as we see here, then there is more power in overall in the EEG over the right hemisphere. You can remember this as an upright trend. So the right goes up, and if there's more power over the left hemisphere, then the trend will go down. So here we see that this difference in asymmetry that we see in the absolute asymmetry trend is actually driven first by an increase in power over the right hemisphere, and then by actually a decrease in power over the right hemisphere or a relative increase in power over the left hemisphere. Sometimes the asymmetry indices can be a little difficult to interpret. I like particularly the asymmetry spectrogram, and this is very similar to the color spectrograms that I showed you before, except that instead of the colors being the amount of power over one region of the brain, this trend shows the difference in power at specific frequencies, right versus left hemisphere. If there's more power in the right hemisphere, then this trend shows red. And the redder it is, the more asymmetry there is. If there's more power over the left hemisphere, then this trend will be blue. The more power, more asymmetry there is, the more blue it will be. So if the EEG was absolutely symmetric, this trend would be completely blank. Here we can see that initially there's a little bit of asymmetry with more power in the alpha frequency band over the left hemisphere, then an increase in power in the faster frequencies over the right hemisphere, and then finally a relative increase in power over the left hemisphere. This is actually driven by a decrease in power over the right hemisphere. So initially more power on the right, and then less power on the right, or more power on the left. And here's just an example of this trend in use for seizure detection. We can see that there's an increase in power over the right hemisphere compared to the left in the color spectrogram. And this shows up in the relative asymmetry spectrogram as red over that same time period. So you can see this change in the right to left power distribution, both in this asymmetry spectrogram, but also in the absolute and relative asymmetry indices. So here corresponding to this difference, here corresponding to this asymmetry spectrogram. So the asymmetry trends have many clinical uses, picking up focal seizures, but in particular for this topic today, it's very useful for detecting ischemia as well as other focal changes in the EEG. All right, so I'm going to come back now to our sort of representation of the EEG changes that occur with ischemia, and talk about some of the clinical uses of EEG and quantitative EEG. So it was first noted that EEG could be useful during monitoring for occlusion of the carotid artery during carotid endarterectomy. And that EEG could be very useful in detecting changes in cerebral blood flow. And when the carotid was clamped, there was initially hemispheric EEG slowing, and this was found to correlate to moderate to severe reductions in cerebral blood flow on xenon CT scanning or perfusion CT. Some of the significant changes were a gradual reduction in the amount of power in the EEG, and a decrease in the frequency of the posterior dominant rhythm that correlated with the degree of decreased cerebral blood flow. So an initial 8 Hertz dominant rhythm would slow down to about 6.5 Hertz with a modest reduction in cerebral blood flow. So I'm going to give an example now of a patient undergoing carotid endarterectomy with clamping of the carotid. Here is the raw EEG. So initially we see sort of a sedated EEG. We see some beta activity. The beta activity is actually initially a little bit more prominent over the right hemisphere compared to the left, particularly in the temporal region. When the patient's carotid artery is clamped during surgery, we see that fast activity over the right hemisphere goes away. And now there's a relative increase or a relative prominence of beta activity over the left hemisphere compared to the right. Now, I would argue that this is a fairly subtle change. If we go back to the previous image, more beta over the right hemisphere, and then intraoperatively now there's more beta over the left hemisphere, but it's a fairly subtle change, and there aren't too many changes in the other frequency components. However, this was a significant change. When the patient's surgery was done and the patient was being awakened from anesthesia, we can see that there's continuous focal slowing, now delta and theta activity over the right hemisphere, maximal in the right temporal region here versus the parasagittal region, whereas the left hemisphere looks fairly normal as this patient is waking up from anesthesia. So this patient suffered an intraoperative stroke, which was detectable using that decrease in beta activity over the right hemisphere intraoperatively. So what would this look like in quantitative EEG? So it's actually far more striking. So, so this is EEG over time along the x-axis. We have several different panels here, including an FFT spectrogram, but I'm going to really focus on this asymmetry spectrogram. So initially, we see increase in power over the right hemisphere, particularly in the faster frequencies over the right hemisphere. More red on that side. Here's where the carotid was clamped, and we see a sudden switch to more power over the left hemisphere. Actually, this was driven by a decrease in power over the right hemisphere. So now there's more activity, particularly in this sort of theta alpha range over the left hemisphere. This worsened over the course of the recording to a greater asymmetry. And here is as the patient is being woken up from anesthesia. And we see again this relative paucity of fast activity over the right hemisphere so that it's more blue in the faster frequencies, and that delta activity, so low frequency being driven predominantly by activity over the right hemisphere. So this is clearly much more noticeable than the subtle EEG changes in the raw EEG. We can also pick up these same changes using an alpha delta ratio. So this is the ratio of activity in the 6 to 14 hertz band versus that in the, 8 to 13 hertz versus that in the 1 to 14 hertz band. And you can see as soon as the carotid is clamped that there's a difference between the left hemisphere seen in blue and the right hemisphere seen in red. And that change worsens as the patient wakes up from anesthesia, and we start seeing that delta activity over the right hemisphere, leading to a significant difference in the alpha delta ratio, left hemisphere versus right hemisphere. We can also see this in the power bands. If we break the EEG down into its component power band frequencies, we can see this decrease in activity in the beta and the alpha ranges, but also in the other frequencies as well. So the whole EEG is actually showing a decrease in activity over the right hemisphere compared to the relatively normally maintained left hemisphere. And here is the same changes now also showing the absolute and relative asymmetry indices. So here we see the sudden change in our spectrogram. We also see an increase in the asymmetry left to right hemisphere. Again, this isn't going to show you the direction of the change, but it will show you that this difference is becoming more severe over the course of the recording and ending up fairly asymmetric. And here we see the relative asymmetry index initially showing a decrease in activity over the right hemisphere or a relative increase over the left hemisphere. And then that left hemisphere predominance remains for the rest of the study. So how useful is quantitative EEG in carotid surgery? This study from 2020 looked at 118 patients who were undergoing carotid endarterectomy. These patients all underwent visual review for ischemia. There were 15 patients who had ischemic changes versus more than 100 who had no ischemia. And when they looked at the ipsilateral trough values of the quantitative EEG measures, these were shown to be significantly decreased for patients who were in the ischemic change group. And the most significant changes were in the alpha, beta, and theta power. And you can see here that there were changes of around 30 to 50% in many patients, and that these changes were most predictive of post-clamp ischemia. All right, so the other common use of quantitative EEG is for detection of delayed cerebral ischemia. This is defined as new focal or global neurologic deficits or new infarcts after subarachnoid hemorrhage. And it occurs in about 20 to 50% of patients with subarachnoid hemorrhage between days 3 and 14, with a peak around days 5 or 6. This results in infarct in a significant fraction of patients, but is often subclinical, results in poor outcome without necessarily a demonstrable infarct, because these patients already may have significant neurologic deficits, and picking up ischemia can be difficult. Risk factors for delayed cerebral ischemia include a poor Hunt and Hess grade and large amounts of cisternal blood, also called Fisher grade 3. Now, subarachnoid hemorrhage is typically caused by vasospasm of large vessels and territorial ischemia, but can also be seen with microemboli, vasospasm of more peripheral arteries, and cortical spreading ischemia. Vasospasm of large vessels, as I mentioned, is the most common cause, and DCI related to that is treatable if it's diagnosed during the reversible phase. So blood pressure can be increased, patients can be given IV fluids to increase blood volume, they can receive intraarterial nicardipine or prepaverin, or even undergo angioplasty to open up the vessels and prevent a permanent stroke. And importantly, there's a fairly long window for intervention because the ischemia is also often mild or moderate, and you have time to intervene before a permanent infarct occurs. Monitoring for vasospasm includes a clinical exam, which, as I mentioned, may have poor sensitivity because the patients also often have neurologic deficits. Transcranial Dopplers, which can be very useful by showing increased resistance, increased velocities. But this is done as a snapshot in time, can't really be done continuously at the bedside. Patients can also undergo conventional angiography to look for vasospasm, or other imaging tests such as CT angiogram, MRI, perfusion studies. Again, these are only snapshots in time and can't be performed continuously at the bedside. So EEG can be done at the bedside and has been recognized for many years as a potential useful test in monitoring for ischemia. The first studies were done by Labar et al. Back in the 1990s, and they looked at 20 patients with aneurysmal subarachnoid hemorrhage using just 2-channel EEG, and they performed a compressed spectral analysis from 1 to 30 hertz, and some trend analysis that included looking at things like the power bands, fast activity to slow activity, or slow activity compared to the total EEG or percent delta. And what they found was that a change in power in their trend analysis picked up 100% of patients who developed infarct on CT, and about 90% of all ischemic events, including those that didn't result in a permanent infarct. And of the test, this percent delta activity seemed to be the most useful, as opposed to the other trends that they use. So this percent delta is comparable to what I'm going to talk about in a few minutes, which is the percent alpha activity. The next large study was from Paul Vespa's group, looking at more than 30 patients with aneurysmal subarachnoid hemorrhage. And he looked at the reduction in variability of the theta alpha content. So this was calculated as the ratio of power in the 6 to 14 hertz band relative to the total EEG, power in 1 to 20 hertz band. And he showed that this had a sensitivity of 100%, but relatively low specificity, because lots of other things can cause changes in this ratio, including changes in intracranial pressure, recurrent hemorrhage, other mass lesions, et cetera. one of the most important parts of this study was that they demonstrated that these changes in the alpha to total EEG ratio preceded the clinical symptoms by a mean of almost 3 days, and also preceded the elevated TCD velocities in many patients. So what does this alpha variability or alpha trend look like? So again, this is the power in the 6 to 14 hertz band versus the 1 to 20 hertz bands. And you can see as we look at this trend over time that there are peaks and valleys as the patient has spontaneous changes in state and arousal. This looks like a New York City skyline. Good alpha variability has fewer excursions and an overall lower amount of power in the vaster frequency band. Fair, even lower excursions and lower total amount of power. And poor looks like somewhere out in Iowa, maybe, with very low amounts of alpha and compared to the total frequencies of the EEG. Here we see the use of this alpha variability trend in actual practice. So this was a patient who was undergoing continuous EEG monitoring. These trends show activity over the frontotemporal regions, left over right, centrotemporal regions, left over right, and parietal occipital regions, left and right. And we can see at baseline that there was a relative decrease in the alpha variability over the right frontotemporal region compared to the left. And the patient had a small hemorrhage in this region. We thought that that was the cause of this decreased variability. But at this point here, we see a sudden change in the alpha variability, most marked over the frontotemporal regions bilaterally, particularly over that right hemisphere, and lower changes in alpha variability over the rest of the brain. And these changes became slightly more severe, particularly over the parietal occipital regions, until the patient had a clinical deterioration and needed to be suddenly stopped moving her legs and became obtunded, was intubated. She was disconnected for a couple of hours to go to angiogram. And when she came back, you can see that the alpha variability has been restored with increases in the alpha variability bilaterally, including in that right frontal temporal region, which had looked abnormal at the outset. Here we see the baseline of the EEG. So these changes are obvious in the raw EEG as well. During that period where she had the clinical change with leg weakness and confusion, we see this high voltage delta activity, maximal over the frontal regions bilaterally and a little bit more severe over the right hemisphere. And then when she had a clear clinical deterioration, the EEG becomes very slow and disorganized overall. Next, Clausen et al. Looked at nearly 80 patients who had continuous EEG from post-op day 2 to post-op day 17. They looked at 1-minute clips of the EEG over time, and these clips were done both at baseline and then at follow-up between days 4 to 6, when patients are at highest risk for deterioration. 9 of their 34 patients developed delayed cerebral ischemia, and they found that the alpha delta ratio, which is the ratio of alpha 8 to 14 hertz versus 1 to 4 hertz, had the strongest association with delayed cerebral ischemia, with a median decrease of ADR was about 24%. And they defined a few clinically useful cutoffs. So if they had 6 consecutive recordings with a more than 10% decrease in ADR from baseline, so 6 hours of a 10% decrease, had a sensitivity of 100% and a specificity of 76%. And then similarly, any single measurement with a more than 50% decrease showed a sensitivity of 90% and a specificity of about 85%. So how would we use this in clinical practice? So here's an example of a patient, again, looking at alpha delta ratio over the left versus right, frontocentral, centrotemporal, parietal occipital. We can see a sudden initial decrease in the alpha delta ratio over the left hemisphere. And then several hours later, or about an hour later, over the right hemisphere as well. This patient unfortunately had very severe global vasospasm, and that was not able to be effectively treated. Here's the raw EEG for that patient, showing the initial slowing and loss of fast activity over the left versus right hemisphere, left parasagittal versus right parasagittal. And then when the trend showed that global decrease, we see diffuse background slowing. Now, these changes can be visible on many of these trends. So here we see a trend where we can see a sudden change in activity over the left and right hemisphere, more slowing over the right hemisphere compared to the left, and a loss of fast activity. But these changes are much more noticeable using the asymmetry trends. We can also see them very clearly in our alpha delta ratios. So this top is left versus right hemisphere, right being red, blue being left. We can see that sudden change in the alpha delta ratio. Here we have over the anterior regions of the head and the posterior regions of the head. And again, clearly separated out alpha delta ratio. And here we see the same changes on our asymmetry spectrogram. Here's another example of a patient who didn't have a significant asymmetry in the alpha delta ratios, but a gradual decrease in alpha delta bilaterally. And this is a patient who had actually went into atrial fibrillation and had a global decrease in perfusion. And when the rapid AFib was controlled and perfusion was restored, the alpha delta ratio improved slightly globally. And here was the raw EEG at baseline, and then the diffuse background slowing when the patient was ischemic. So I'm going to show a couple of other cases. This is a 56-year-old man with a subarachnoid hemorrhage, Hunton-Hess grade 3 and Fisher grade 3. He had an ACOM aneurysm, which was uneventfully clipped. And here we see his initial alpha delta ratio. This is about 24 hours after his clipping, and we can see a gradual decrease in the alpha delta ratio bilaterally without too much asymmetry. And the asymmetry index does not show too much difference from side to side, but a gradual decrease in alpha delta ratio suggestive of decreased perfusion globally. This is the EEG at 30 minutes. There was a little bit of slowing over the left hemisphere. And then as the ischemia became more severe, the EEG showed diffuse background slowing. And this is the same time period, showing alpha variability as opposed to the alpha delta ratio. So here we're looking at these initial nice excursions that are bilateral with a lot of variability initially, and then the overall decrease in the ratio, as well as a decrease in the variability of the EEG over time. This patient actually had increase in blood pressure and had improvement in the alpha delta ratio. If we look at 16 hours of EEG, there was improvement at the end of the study after institution of hypertensive therapy. The next case is a 62-year-old woman with a subarachnoid hemorrhage. She had a Hunton-Hess grade 2 and a Fisher grade 3, so high risk for vasospasm. And she had 2 aneurysms, an internal carotid and a 4-millimeter left anterior communicating artery, and both of them were clipped uneventfully. And here was her initial alpha delta ratio about 12 hours after her clipping was performed. And what I want to point out here is the this concept of variability. So we see that there's a difference between the left and the right hemisphere, suggesting ischemia on the right. But the main difference is this decrease in reactivity of the EEG. Here we see a nice increase in alpha activity as the patient is aroused over the left hemisphere, but that's very blunted over the right hemisphere. And so often the first change that we see on these alpha delta ratios is a difference in the alpha and delta at times when the patients are alerted. And we can see that in several places in this EEG. However, with time, the EEG becomes less variable, and we start seeing a persistent change between the left in blue and the right in red hemispheres. This is actually maximal over the posterior head regions, not over the anterior head regions. And here in our alpha, in our relative spectrogram, we can see an increase in delta activity that's most marked in the low frequencies over the right hemisphere. And then by day 4, this difference in the alpha delta ratio is far more pronounced. The patient had an infarct in this region with a fixed deficit, a fixed difference between the left and the right hemispheres with really marked increases in delta activity over the right hemisphere indicated by red on our asymmetry spectrogram. So there are several confounders for quantitative EEG for delayed cerebral ischemia. Almost anything that affects the EEG can decrease the sensitivity, sedation, increased intracerebral pressure, reductions in perfusion pressure overall, metabolic changes, hydrocephalus, focal edema, artifacts. And so you need to have sort of a systematic approach when you see these changes on quantitative EEG to make sure that there is no other cause for the changes that you're seeing on the EEG. One way to increase the sensitivity and improve the signal to noise ratio is to use intracortical EEG. This study from the Columbia group looked at 5 patients who had poor grade subarachnoid hemorrhage and looked at an 8 contact depth electrode to monitor for ischemia. And they saw that in 3 patients who had vasospasm, the mean intracranial alpha delta ratio decreased by 42% for those with vasospasm versus only 17% without. And that this intracortical EEG dropped by at least 25% for more than 4 hours in all patients who had vasospasm. So this invasive EEG may be more useful than raw EEG or scalp quantitative EEG. So what do we do in clinical practice? Our subarachnoid protocol here at Barrow is to begin monitoring as soon as possible after clipping or coiling. We typically do this on post-op day 1, and this allows us to establish a baseline for changes that occur over time. We then monitor from days 2 to 14, or for patients who are doing well until they're discharged from the ICU. And we use both raw EEG, although it's difficult to pick up ischemia on raw EEG, and a set of quantitative EEG trends, really focusing on the alpha delta ratio, but also using an alpha variability trend. The nurses stimulate the patients every hour, and our technologists mark the periods where the patient is being stimulated so that we can look at these successive segments and determine whether there's any change in the alpha delta ratio over time. And we use both, as I said, alpha variability, asymmetry indices, and the alpha delta ratio. So how useful is this overall? A systematic review of 8 papers were identified from a large number of citations looking at ischemia. They found that all of the papers were from single center. About half of them were retrospective. All of them were highly biased, meaning that there were investigators knew which patients were being selected and which trends were being used for those patients, and that the EEG methodology as well was also biased. They used as the reference standard both CT and digital subtraction angiography, as well as TCDs. 4 of the studies, the DCI was based just on the clinical diagnosis. The presence of changes in alpha delta ratio or other quantitative EEG measures was useful, but they were not able to make a strong recommendation because of the high level of bias in these studies. So they finally concluded that continuous EEG monitoring after subarachnoid may predict clinically symptomatic episodes of DCI many hours in advance, but they don't know whether this actually translates into improvement in outcome for these patients. So this has been translated into guidelines for continuous EEG monitoring. The ACNS guidelines for adult and pediatric patients recommends monitoring for ischemia in patients with subarachnoid hemorrhage, as long as the EEG can be monitored multiple times per day to determine whether ischemia is developing or not. But still, EEG for ischemia is not used as frequently as continuous EEG for seizure detection. We can see here from a survey in 2014, almost everyone, ICU attendings and neurophysiologists, use continuous EEG for seizure detection, but 20 to 25% use it for ischemia detection. Again, largely related to issues of duration of monitoring and lack of familiarity with the monitoring procedures. So now I'm going to switch over and talk about ischemic stroke. So in this study done back in the 1980s, EEG was found to be useful for monitoring for stroke. 90 patients, of those who had normal CT scans initially, nearly 50% showed lateralized EEG abnormalities, and all 16 of these later showed infarcts on CT. And of the 60 patients with cortical infarctions, there were lateralized EEG abnormalities in about 80% of patients with middle cerebral artery stroke and 86% of those with watershed stroke. However, lacunar infarcts had normal acute EEG, again, related to the severity and the amount of EEG, amount of the brain that's affected. Now, EEG can be useful in prediction of a malignant course after ischemic stroke. This pattern, RAWAD, known as regional attenuation without delta, initially described by Ken Jordan, was seen in patients with large ischemic stroke. And these patients are less likely to benefit from thrombolysis because they already have significant tissue destruction at the time of the initial EEG. And these patients are likely to develop malignant cerebral edema with risk for herniation and death. So here's an example of that. This is a 77-year-old woman with a history of multiple stroke risk factors who had sudden onset of left hemiparesis. She had a right ICA mechanical thrombectomy, but her CT, even early on, showed right ACA and MCA territory infarcts. And she then developed episodes concerning for seizures. So this is her initial EEG. We see over the left hemisphere a mixture of theta and some faster frequency activity, but over the right hemisphere, both parasagittally and temporally, we see severe background attenuation and really no significant delta activity. It's just severe attenuation and loss of fast frequencies. And we see that over on our trends as well, with loss of all of this fast frequency, theta, alpha, delta, theta, alpha, and beta activity, which we don't see at all over the right hemisphere. And our asymmetry index shows power is much more high over the left hemisphere in all frequencies. However, over time, we start seeing over the left hemisphere a gradual increase in delta activity, represented here by the white and the red and the low frequency components. And this is a little bit surprising, right? So we're looking at a right hemisphere stroke, and we're seeing sudden increases in activity over the and in delta activity over the left hemisphere. If we look at what's going on in the raw EEG, we see increases in delta activity, so focal slowing over the left frontal and left frontotemporal region, some sharply contoured discharges here. And these changes, this rhythmic delta activity, occurred in bursts over time. Whenever the patient was stimulated, she would have these large increases in delta activity of the left hemisphere. And this was related to increased intracranial pressure and transtentorial herniation. So this delta activity actually represents herniation and slowing rhythmic delta activity over the left hemisphere related to increased ICP. The alpha delta ratio here was actually a little bit misleading because we see just a slight decrease in the alpha delta ratio left versus right because of this rhythmic delta activity. The asymmetry was not as great as you would have expected. So in 25 patients with large MCA infarcts, half of whom had a malignant course and half of whom had a benign course, the EEG was started within 24 hours and underwent visual analysis. And patients who developed diffuse slowing, slow delta activity, and loss of beta activity over the ischemic hemisphere were much more likely to have a malignant course of their stroke and increased intracranial pressure and cerebral edema. So some of the confounders on ischemic stroke can be spontaneous or provoked state changes, variations in physiologic parameters, blood pressure, intracranial pressure, et cetera, use of sedating medications, and then EMG and electrode artifacts. There can be other things that cause problems with diagnosis of ischemia in patients with acute stroke. So patients may have seizures and have focal postictal slowing or loss of fast activity. In terms of differential diagnosis, hemiplegic migraine can look very much like an ischemic stroke. Cortical infarcts that are small and lacunar infarcts may not show any EEG changes at all. And then finally, there's almost no data on continuous EEG monitoring in real time for monitoring ischemia in acute ischemic stroke. So in summary, EEG is a useful monitoring tool for cerebral ischemia. It's most useful looking at large vessel territorial ischemia. And here it has good sensitivity and moderate specificity. You need to rule out other causes before you say that this is related to ischemia. Retrospective studies have shown that quantitative EEG measures can be very useful in carotid endarterectomy, subarachnoid hemorrhage, and malignant cerebral edema, but these techniques are limited by lack of specificity and artifacts. There are very few prospective analyses of quantitative EEG in any form of ischemia. And I think given the advances in technology and our ability to do this in real time, it is time for prospective randomized blinded trials comparing patients who undergo continuous EEG monitoring to those who do not in ischemic lesions. I want to acknowledge all of my colleagues, both from ACNS, the Critical Care EEG Monitoring Committee, and the ICU Guidelines Committee, sources of funding from the American Epilepsy Society and the Epilepsy Foundation, and then my continuous EEG monitoring teams, both at Beth Israel and at Barrow Neurological Institute. And then finally, the Critical Care EEG Monitoring Research Consortium, which is now, I think, almost 70 centers that are working to improve the utility and the accuracy of continuous EEG. Thank you.
Thank you, Dr. Herman. That was a wonderful talk. We had a few questions come in. I'm not sure if you have time. I know that you have other places you need to be today. So
my patient is late, so I'm good.
Oh, okay, perfect. Great. Then we'll just go ahead and get started with in the order that they were asked. The first question: thank you for your presentation. As known, not all slowing is secondary to ischemia. How could we differentiate between slowing due to ischemia and slowing from other causes?
Yeah, so this really depends on what the diagnosis is. So for example, if you have a patient with subarachnoid hemorrhage, you're going to have a somewhat limited set of things that you're expecting to happen, one of which is ischemia from vasospasm. And so typically we would rule out other causes. So we call the bedside nurse, we ask about intracranial pressure, we ask about whether they're, if they have a VP drain in ventricular drain, we ask whether the pressure is increased. We look at whether they had recent imaging. Do they have any increase in edema or increase in evidence of rebleeding? Is the patient excessively sedated? So we have a whole set of parameters that we go through and kind of rule out one by one. And then we can do some tests. So we can have the nurse try to wake the patient up, take off the sedation, see whether the EEG improves, increase blood pressure in some cases, put up the head of the bed, or put down the head of the bed if we're worried about perfusion. And then finally, if we see severe changes, then we would take the patient for a perfusion study or for an angiogram to look for vasospasm. It's a lot harder when you don't know the diagnosis, right? So I mentioned that hemiplegic migraine can look very much like an ischemic stroke. So if you don't know what the diagnosis is, then it's much harder to use these trends.
Yeah, that makes sense. Thank you. Next question. This was during the carotid endarterectomy data you were showing. This is a cool example with the carotid endarterectomy, but the alpha delta ratio change appeared to be very subtle until after the patient woke up. Would you have called the concern for stroke based on the alpha delta ratios during the procedure?
Yeah, so that's one of the potential limitations of the alpha delta ratio, is that the fast frequency is often very low voltage and so is going to contribute less to the ratio. So if all that you have is loss of fast activity, particularly beta frequencies, you may not see that very well at all on the alpha delta ratio. And that's where the asymmetry spectrogram can be really useful, because that will show you the ratio of frequencies in each frequency band. So yes, I would have called the concern for stroke based on the alpha delta ratio, particularly using quantitative EEG, but clearly whoever was reading this EEG during the carotid endarterectomy did not notice that subtle change, and the patient unfortunately suffered a stroke.
Right, right.
So
okay, please.
How would the alpha variability appear in alpha coma? So it would not be variable. It would show a high alpha to total EEG ratio, and it would be completely invariant, because as we remember, alpha coma is all alpha and very little other frequency, and it is unreactive. So it would just be high alpha delta ratio, bilateral, and unchanging. And then next question is, does the baseline alpha delta ratio need to be reset over the days after the subarachnoid hemorrhage as the patient's overall level of consciousness improves? Or do you continue using the same baseline ratio that was initially calculated at the beginning of the recording? So unfortunately, you have to do a little of both, right? Because sometimes these changes can be very slow. And if you're only using like the last 6 hours or the beginning of the day, you may actually miss a very slow trend in decreased alpha delta ratio over time. Once the patient has developed vasospasm, however, then you need to kind of look at how things change related to the most recent alpha delta ratios. And it can become very, very complicated to tell whether somebody's developed worsening ischemia over time. Looking back at the initial alpha delta from the initial baseline recording, and you should do that on a daily basis, but then also looking at the changes from the baseline for that particular day for patients where they've already developed some changes and you're looking to see whether they become more severe. And then, is there a normal range for ADR in general? Well, I wish I knew that. Certainly, you see alpha delta ratio in a normal EEG that's somewhere around 1 or greater than 1, but this is very difficult to make a prediction of what a normal alpha delta ratio is. You kind of have to set a baseline for each individual patient and then go from there. All right. Oh, sorry, more questions. Rationale for moving time window size. Is that for alpha delta ratio? It's a little different for alpha delta versus alpha variability. So, it differs from study to study. We use for the alpha delta ratio, we use a 2-minute average of the alpha to delta ratio. For alpha variability, I do 30 seconds because you want to look at variability. So if you average out over longer time segments, you lose that variability component. But there has not been a lot of research done on, exactly what time window would be optimal for detection of ischemia, as far as I'm aware. All right.
Okay, thank you very much. And okay, I want to thank everyone for coming, and thanks to Dr. Herman for the wonderful talk.
All right, thank you, everyone.
Okay, thanks everybody. Bye-bye.
Bye-bye.